Welcome, everyone. Please scan the, can you go back to the QR code? Please scan the QR code to check into the session. Leave it up for just a moment more while people come in and get seated. Welcome to scientific session number 6 on quality and stewardship. I would like to welcome our moderators to the stage. Dr. Matthew Santori is an associate professor of surgery at Emory University School of Medicine and pediatric surgeon with Children's Healthcare of Atlanta. And Dr. Afif Khalilat is an assistant professor of surgery at Penn State Health. All right, now we can move to the slide, and thank you.
Thanks very much. We're going to start with the first presentation. It's entitled Heating the Black Box, Leveraging National Surgical Quality Improvement Project, Pediatric for Hospital Level Assessment of Opioid Prescribing. This is done by Dr. Mallory Perez.
Thank you for the opportunity to present. This work was funded by the NICHD through a 2-year R21, and we have no further disclosures. The importance of this study is reflected in the over 3 million children each year that undergo surgery in the United States, many of whom receive opioids. Yet we still have no national opioid prescribing benchmarks. The AAP has issued a challenge to surgeons to decrease opioid prescribing by 50% at discharge. However, stewardship efforts must balance adequate pain control with the risk of opioid-related harm. To find this balance and optimize post-opioid prescribing practices, we need a better understanding of the extent and the drivers of opioid prescribing practice variation. This is why we conducted this research, to explain variation across hospitals. We started by looking at the FDA's guidance as a place where performance is not currently nationally benchmarked. The FDA issues contraindications and warnings. Contraindications apply when a product is not recommended due to the potential for harm, the never events, while warnings are alerts that are considered for emerging concerns, calling for increased caution. We hypothesized that opioid prescribing practices at discharge in compliance with FDA guidance varies significantly across hospitals and subspecialties. Our study utilized expanded ACS National Surgical Quality Improvement Program pediatric data with 19 additional variables from all 4 Illinois children's hospitals participating in the program. Children aged 5 to 18 years old undergoing any operation in the sampling frame were candidates for inclusion. We had 3 outcomes. Our first was whether or not an opioid was prescribed at discharge, representing the extent of opioid prescribing. The second was total morphine milligram equivalents prescribed, representing the intensity. And the third was the proportion of patients for whom the hospital was FDA compliant. Finally, among those receiving opioids, we conducted a multivariable linear regression to identify factors associated with total MME at discharge. Our cohort included nearly 1,700 patients, of which 34% received opioids at discharge, ranging from 26 to 44%. In this table, we explored the proportion of opioids prescribed stratified by specialty. The 3 most common specialties are shown, and the final column is the percent change, which exemplifies the degree of variation across hospitals. For general surgery, you can see that overall there's 15% of patients that received opioids, with a 300% change across hospitals ranging from 5 to 20%. For our next outcome, mean total MME at discharge was 97. This graph highlights the importance of looking at both the intensity and the extent. The extent is the left y-axis and the intensity is the right. Ortho, plastics, and gynecology most frequently prescribed opioids at discharge, while general surgery, neurosurgery, and ortho were the highest total MME prescribers. Stating this another way, for general surgery, we can see that while opioids were infrequently prescribed, they were often prescribed at a greater intensity than many other of the specialties. Our linear regression shows hospital site, adolescent age, orthopedic surgery, neurosurgery, and multimodal analgesia were associated with increased total MME. For FDA compliance, you'll see by the overwhelming green on this table that compliance with contraindications was strong, with most at 100%. However, compliance with a warning on benzodiazepine and opioid co-use demonstrated high variation from 46 to 93%. We talk a lot as a community about opioid stewardship. So how do these results apply to a national sample? This study uniquely covers multi-specialty hospital level variation. However, the findings represent our select population, of which over 70% were privately insured. While a crucial forward step, the generalizability of state-level data remains unknown, particularly for pediatric patients. As seen in this map on the right, Illinois is among the moderate dispensing states in the US. Therefore, we surmise that national variation likely exceeds that which was observed in the state of Illinois. Excitingly, ACS-NSQIP, as of January 2023, has started collecting this more detailed opioid prescribing data for the over 150 hospitals that are in the program. Through this study, we've shown that detailed data collection is both essential and feasible, and going forward, research should consider both the extent and the intensity. We observed that many patients, over a third in the NSQIP sample, are discharged on opioids, and compliance with FDA contraindications was encouraging. National benchmarking is on the horizon. Our next steps are to explore specialty-driven, procedure-specific variation, identify factors associated with benzo and opioid co-use, and investigate the relationship between multimodal analgesia and opioids at discharge. Thank you for this time and this team, and I'm happy to take any questions.
We'll open up for discussion.
Hi, Jill Whitehouse, Hollywood, Florida. Are there any orthopedic surgeons in here? No? Okay. How would you suggest we tackle that? How do you suggest we convince orthopedics to do what we as general surgeons have done? Because I would think that we all have dropped narcotics from operations we were taught. There's no way you could do that without narcotics on prescription. And they don't listen.
Mm-hmm. I think part of the challenge is to identify which orthopedic surgery operations are the drivers. So I would say that we need more granular detail before we can convince people that are going to be a little bit more resistant to change. And ultimately, what we need to show is that it doesn't increase readmission or poorly controlled pain in the end. Fortunately, in our sample, less than 2% of patients had a follow-up visit for a pain-related concern. So like I said, we need more data and I think a broader sense of the variation, particularly if there's an orthopedic surgery department somewhere in the country that's doing really well. I think that information can be really helpful coming from their colleagues and also showing that it doesn't have negative consequences.
I think you can also leverage your EMR so they can actually put a block on it where the BMI ties into the age. And if it pops up, it can be, you can't order it. Here's what we suggest instead.
And I also just want to make a note. I think we're not advocating that we should do away with opioids for all operations. This is more so that we find the right balance. And for orthopedic operations, again, depending on what the procedure is, some of these opioids and even benzodiazepines may be appropriate. So we need more information to sort that out.
Very good. Thank you.
I'd like to introduce next Dr. Fari Fall from Nemours Children's Hospital to be discussing increasing caudal block utilization. Sorry. Is that the right presentation? Yeah. The next presentation we have is increasing caudal block utilization to promote opioid stewardship in the NICU population. Nobody. Okay.
Do we have a presenter? I'm sorry? Dr. Ball here?
Or is anyone from Nemours?
Got it. The list is just inaccurate, that's all.
Okay, sorry.
We don't have a correct list. Which is the next one?
Oh. Sure. Okay. All right. Sorry about that.
Which is the next one?
Okay. Let me just
I'll move on to that one. All right, sorry about that. We are going to move on. So the next presentation is a utilization-based approach to reduce operating room costs and improve efficiency for pediatric inguinal hernia repairs. Presented by Dr. Lika Devara.
Thank you for this opportunity. I have no financial or non-financial disclosures. So I did this research to gain a better understanding of surgical systems with the idea of understanding the fundamental role of preference cards in dictating resource availability within the operating room, and gain an insight on the costs of commonly used disposable items and the processes for managing them. I'm presenting this research because I believe that we've come up with a reproducible solution to mitigate superfluous costs within the operating room for high-volume cases. The problem we face today is that the cost of U.S. health expenditure rose to $4.5 trillion in 2022, which is an almost 200% increase from a decade ago. 1/4, or approximately $1 trillion of that expenditure, is predicted to be from the operating room cost. This is in addition to the environmental costs of all disposable items that contribute to the massive OR carbon footprint. We believe that PC, or preference card optimization, holds potential to efficaciously and reproducibly lower cost and return rate for commonly performed procedures as observed in our project, specifically with pediatric laparoscopic inguinal hernia repairs. The setup of our project involved gathering pre-data of preference cards and 1 year of retrospective pediatric inguinal hernia repair disposable items and cost per case for 5 surgeons in one division at our institution. We then performed our intervention and collected the same data 1 month and 6 months post the intervention. Our intervention included 4 key steps. First, we created a heat map that was a visual representation of item utility and cost for each surgeon. Each surgeon was given the opportunity to consider whether an item should remain, be removed, or replaced on the preference card without pressure or commentary. For higher cost items, like trocars, costs of various available brands and sizes were provided, and the surgeon was free to choose their preferred item. Focus was placed on items with 40% utility or less. Next, we had a multidisciplinary meeting with the OR service line coordinator, surgeon project lead, surgical technician, and intraoperative nurse to further review the new preference cards. Their perspectives focused on patient safety devices, even if utilization was low. Examples such as disposable pads for pressure points and heating blankets for temperature control were further discussed. And par levels of commonly used items in the operating room, standardization of commonly used items such as sutures, and processes of finding these materials that were to be removed were evaluated. Finally, the new preference cards were implemented into the EMR in June of 2023, and the surgical team was educated on all the changes that were made. Pre-intervention data was based on 74 cases. Surgeon preference cards included an average of 44 unique disposable items, and item utilization ranged from 0 to 100%. After evaluation by the multidisciplinary team of key stakeholders, an average of 16 individual items was removed from each surgeon's preference card, while retaining any items that were particularly requested by the surgeon. 6 months after the intervention, we were able to show a significant reduction in average return rate and costs of items per case across all 5 surgeons within the department. To take a closer look at the numbers, 1 month after the intervention, our return rate was reduced to 33% and disposable item cost per case to $136.69, yielding a 12.2% reduction in return rate and an average $93 cost savings per case. Surgeons were questioned at this time point and no one requested further changes. 6 months after the intervention, 25 cases were evaluated, and the return rate was reduced to 35%, with disposable item cost per case reduced to $161.84. This was a 10.2% reduction in return rate and an average $68 cost savings per case, and these values reached statistical significance. In summary, this was a direct savings of approximately $1,700 to the health system for 25 cases over 6 months at our institution. However, there are also indirect savings through salaried personnel who pull the items, charge the items, and return the items that were not included in our study. Our project also differs from most that were done in regards to preference cards because we did not standardize the preference cards, and each surgeon was able to maintain their autonomy and preferred surgical techniques while still demonstrating significant savings within the time period. And both pre and post intervention, there was a significant variability in surgeon cost per case. However, over the 6-month time period, each surgeon had a reduced cost. The study was also dependent on manual entry of item usage in the OR at our institution, since we do not have an automated scanning mechanism. However, each item is reviewed by 2 separate team members, including the intraoperative nurse who charges for the opened items and the materials management staff who catalog the returned items. Therefore, we believe the documentation is largely accurate. In conclusion, the optimization of surgeon-specific preference cards significantly reduces return rate and disposable item cost per case for pediatric laparoscopic inguinal hernia repairs, and this improvement is maintained over time. And in the future, we hope to implement this intervention model for other high-volume procedures at our institution and streamline the process that we have come up with to create an operating room software to provide heat maps to surgeons and staff in real time. I'd like to thank my co-authors and my PI, Dr. Walsh, and the OR personnel at our institution for making this project a reality.
We'll open up the floor for discussion.
Hi, this is a great project. I'm Rob Weinsheimer from Swedish in Seattle. Did you look at how often people had to run out of the room to grab an item that wasn't on the card and look at operating room time? Because that's always the balance, right? If it's especially with travelers and staff that aren't, really consistently working with you, then it's sort of, they get lost in the abyss of trying to track down things.
Yes, so when we had the review with the multidisciplinary team, that was a big point that kept coming up. And so any items that were too far away or located in central core and the time that would take for someone to go grab it and the time under anesthesia were taken into consideration. So certain items that might have had a lower than 40% utility were still maintained on the preference cards if those other costs kind of overpowered the cost of removing the item.
I had one question for you. I know you're looking at cost, and I think this is something that everybody struggles with, getting your preference cards right and decreasing the variation. And one thing that you, I don't know if you looked at, but sustainability and energy costs, right? This is one thing that when you decrease the amount of waste, you actually decrease your energy use. Have you looked into that?
Not yet, but that's definitely a future direction that we want to take. I think we also initially were pleasantly surprised with how much of an impact these small changes made, and kind of looking at how this small scale, if applied to high volume cases across the institution, could have a real impact. We definitely want to look at more of the energy savings as well.
I think in the interest of time, we'll have you guys connect at the end, and we're going to move on.
Thank you.
Thank you very much. Thanks very much. The next presentation is to delay or not delay cost analysis of early versus delayed outpatient repair of inguinal hernias in premature infants. Dr. Gwyneth Sullivan will be presenting.
Hello, thank you for the opportunity to share our work. We have no disclosures. The purpose of our study was to determine from a cost perspective in premature infants that were diagnosed with an inguinal hernia in the outpatient setting, whether it made more sense to do the repair in an early fashion or a delayed fashion. We think this is particularly important as going forward with value-based care, considering cost is a key element of this. Very often, premature infants who are diagnosed with needs that require an elective surgery in the outpatient setting are often admitted for observation post-operatively for apnea monitoring. This varies a bit from center to center, but there's an increased cost that's associated with that overnight observation. This creates an interesting dilemma for especially cases like inguinal hernias, where by delaying repair, you're increasing the risk of incarceration and thus a more urgent repair that would require an increased cost as well. This led us to our study question to kind of help encounter this scenario for pediatric surgeons and the practice variation that's ongoing, to look at the estimated cost that's associated with early versus delayed outpatient repair of inguinal hernias in premature infants while considering this increased risk of incarceration with delayed repair. This was a cross-sectional study that used the total hospital costs from our single academic institution. we estimated cost for 3 scenarios. And the first was early repair that would require an overnight observation for apnea monitoring, delayed repair that would not require that overnight observation, and then a scenario in which an urgent repair was required for a patient that presented with an incarcerated hernia, which was successfully reduced, but then would require a period of observation prior to repair to help reduce edema for the perioperative setting. This would be a total of a 3-day hospital admission. For our incarceration risk of delaying repair, we used literature-derived ranges of 0.1% to 4% per week. For the timing of delayed repair, we looked at our own institutional policies and then also societal guidelines and found that most centers ranged from 50 weeks to 60 weeks where they would delay repair or until they would require no observation for apnea monitoring in an elective setting. To do this analysis, we did a decision analysis model where essentially a patient who came in diagnosed outpatient with an inguinal hernia would either undergo early repair or plan for delayed repair. And then those that undergo delayed repair could either present for urgent repair with an incarceration or delayed repair at the appropriate adjusted gestational age where apnea monitoring would not be required. In our base model, we used an incarceration risk of 0.5% per week, and then we timed the delayed repair for 50 weeks adjusted gestational age. We performed a sensitivity analysis where we altered the incarceration risk from 0.1% to 4% per week, and then we also altered the age at repair from 55 weeks to 60 weeks, for which a delayed repair could be done without apnea monitoring. So these are the results from our base model. And again, this is for a premature infant diagnosed in the outpatient setting. On the x-axis, you'll see the age at diagnosis, with early repair being done at that time of diagnosis. And you'll notice it's a fixed cross across the entire axis there. We found that the estimated cost for early repair with overnight observation would be about $24,000 at our institution. For delayed repair, which incorporates the estimated cost for those that would present with incarceration with a risk of 0.5% per week incarceration, then at the earliest time of diagnosis, 35 weeks, it would be about $17,000 accounting for that risk. This would mean a cost difference of about $6,000. And what you'll note is at no time point for age of diagnosis would it make more sense from a cost perspective to repair these in an early fashion as compared to a delayed fashion. For our sensitivity analyses, again, the black line here is the fixed cost of early repair, and you'll see we have 2 different graphs for the different adjusted gestational ages that delayed repair could be done without apnea monitoring. And then you'll note that each of the dashed lines represents a different weekly incarceration risk of the inguinal hernia. And what you'll note is that we do see in a few different scenarios where delaying repair would have overall a higher estimated cost. This is really only at a very early diagnosis of the inguinal hernia, and then also if we're considering an incarceration risk at a relatively high rate of 4%. The study is limited in the way that we designed our analysis and some of the variables. For example, we did not include the need for potential emergent surgical intervention were a patient not to have their hernia reduced if it was incarcerated and there was concern for strangulation. However, this scenario is very rare. And then we also assumed a post-reduction waiting period to allow for edema to increase. This is assuming that many of these are still done open. However, if the repairs were done laparoscopically, this would not be a factor that would need to be considered. Finally, these are single center cost estimates, and they would likely vary at different centers and with different surgeons. So our conclusions were that based on cost alone, delaying repair until after a premature infant who is diagnosed with an outpatient inguinal hernia no longer required overnight observation for apnea monitoring would be preferred. However, there's definitely other factors that should be considered, specifically certain clinical scenarios, and then also family and caregiver preference, and then overall quality of life. I'd like to thank our whole study team, and I'll now happily take any questions.
Any questions from the audience? One of my questions is, did you take into consideration recurrence and recurrence rate into your cost analysis?
Yeah, that's a good question. We did not specifically look at recurrence during this time frame. I know there's been some recent studies that have shown that recurrence may be higher, especially if these are repaired in the inpatient setting while patients are still in the NICU, but that wasn't a factor that we looked at.
Hey, David Rothstein from Seattle. Do you know why overnight stay is mandated? I think we all sort of know it's overnight, but it's really 12 hours. And in our place, we actually sometimes get away with 4 to 6. I don't mean to get away with it. The anesthesiologists have been changing. So you could do morning case and then go home at noon or 12 without the same cost. I don't know if that's an option at your institution.
Yeah, I think it widely varies by institution. And I looked at the Society for Anesthesiology's guidelines on this too, and they don't really definitively say a specific week. I've seen data saying even up to 45 weeks is safe to not have to admit for observation for apnea monitoring. Our institutional policy is 50 weeks, but even anesthesiologists specifically will say up to 55 sometimes. So I think there's definitely some opportunity there to align and further study those issues.
Is there any possibilities of using this model for other different types of disease processes or surgeries?
Yeah, I definitely think it's a great model to use for situations where it kind of models out the different scenarios for, in this case, whether or not we'd be able to safely, from a cost perspective, delay the repair. I think anything that has that kind of, previously this has been well applied to, for example, LADS procedures and malrotation at a specific age at which it might not be necessary to correct that. So any kind of disease process that has those elements, this could be applied to.
Great. Any other questions? If not, we'll move on. Thanks very much.
Great, thanks.
All right, our next presentation is Less is More, Improving Antibiotic Stewardship with Shortened Courses for Pediatric Appendicitis, being presented by medical student extraordinaire Benjamin Tomei from Lurie Children's.
It's a great introduction. Thank you, and thank you to APSA for the chance to present today. Oh, we have no disclosures. So we conducted this research to achieve more efficient care for our patients at Lurie Children's by decreasing unnecessary exposure to antibiotics. And this is important because acute appendicitis is one of the most common pediatric surgical emergencies and has a significant burden of antibiotic usage. Short-term postoperative antibiotic regimens are not universally adopted. And this is despite APSA guidelines of 5 to 7 days of antibiotic use, evidence from the Stop It trial that shows that 4 days of antibiotics and adequate source control is safe in patients, and pediatric cohort data showing that 5 days is safe for children meeting discharge criteria. And not only are extended antibiotic use patterns unnecessary, but they can be harmful, especially when contributing to antibiotic resistance, increased hospital infections, as well as higher costs of care. So in the spirit of these tenets of antibiotic stewardship, our team at Lurie Children's in Chicago updated our clinical practice guideline to decrease antibiotic utilization in appendectomies. We performed a single institution prospective observational study for children undergoing laparoscopic appendectomy. From July of 2019 to June of 2022, our antibiotic regimen was 3 days for gangrenous appendicitis and 7 days for perforated appendicitis. And these regimens were ceftriaxone and metronidazole with the transition to amoxicillin and clavulanic acid orally at discharge. Starting in July of 2022, we decreased the regimen to 2 days for gangrenous and 5 days for perforated, and the adherence rates for both protocols were acceptable. The lengthened antibiotic therapy cohort had 475 patients meeting inclusion criteria from the total of 1,100 cases within those 3 years. And the shortened cohort had 160 patients meet inclusion criteria from the total of 350 cases within that year. Both cohorts were stratified on perforation based on intraoperative findings. Preoperative cohort differences and outcomes were assessed with chi-squared analysis and independent t-tests. And our primary outcome was intra-abdominal abscess rate, and our secondary outcomes were related readmission rates within 30 days and the duration of antibiotics given. There were no significant differences in demographics or preoperative morbidity between our patient cohorts. This remained true for patients stratified by gangrenous appendicitis. And for patients with focal abscess, there was a significant difference in gender between these two cohorts, but we didn't find this to be clinically significant. And there was no differences between diffuse abscess. Our results demonstrate significant decreases in antibiotic use with no significant increase in abscess or readmission. For gangrenous appendicitis, we successfully decreased the mean post-op antibiotic duration by 2.3 days. Abscess rates were similar at 1.6 and 2.1% for the long and shortened cohorts, and readmission rates were less than 5%. For patients with focal abscess, we decreased antibiotic use by an average of 1.4 days, with abscess rates of 5.6% and 7.5% for the cohorts, which were not significantly different. They had 30-day readmission rates of 6.5 and 9.4%. And similarly, we decreased antibiotic duration in the patients with diffuse abscess, this time by an average of 0.7 days. These patients had expectantly higher rates of intra-abdominal abscess compared to the previous subcohorts, with 18.9% and 16.6% enduring abscess in the long and shortened cohort, respectively. And these 30-day readmission rates were also not significantly different. So in the context of all the other pediatric cohort data and trials, our abscess and readmission rates were acceptable in our shortened cohort. So in conclusion, in this study, we demonstrated that our clinical practice guideline was an effective and safe strategy to decrease antibiotic use in appendicitis, specifically 2 days for gangrenous, 5 days for perforated. And we advised surgical teams to consider conducting institutional stepwise decreases in antibiotic use to further stewardship efforts. I'd like to thank Dr. Mayhill-Ravel, as well as Dr. Sullivan and Dr. Lehane for their mentorship throughout this project. And thank you all for being here, and I'm happy to take questions.
My question for you is, where are we going to stop? So we already know we've got data from Kansas City that says we don't need antibiotics in gangrenous appendicitis, even though it has a higher SSI rate. Antibiotics don't help. You're at 5 days. Everyone, whenever I have residents on my service, they always want to know why we're not following the stop it trial. Why aren't we at 4 days? Are we just going to keep going to the point that we realize antibiotics doesn't make a difference? Just send them home without them? And if they get infected, bring them back and put them on antibiotics, or what?
Yeah, that's a great question. At least at our institution, I could say that further decreases, we're going to try to create more like trial-based instead of quality improvement initiatives, just get better data. But that's a good question. There's definitely evidence that some of these intra-abdominal abscesses it's due to bugs that are they're resistant to the antibiotics we're giving. So it poses the question of what's the next step to target all these folks, whether that's, I don't know if anyone heard the talk on phototherapy this morning, which is really interesting, and in the rat studies, or some amount of like immunotherapy, or like, yeah.
Sharif Emile, Montreal. It was really nicely presented. Congratulations, and congratulations on doing this work, and congratulations also on not talking to us about perforated appendicitis. You're classifying what we're actually speaking about, and we should be doing that. I have a lot of comments, but I'm just going to restrict them to 2. So I would submit that gangrenous appendicitis is not a thing. They really do behave like just simple appendicitis. We've shown in some prospective studies you do not need to treat these patients with antibiotics afterwards. Our colleagues from Columbus showed that. Sean Rangel recently published some data showing that if you have gangrene, maybe the outcomes are a bit worse, but antibiotics do not make a difference whether you give them or not. So I would submit that when you see a gangrenous appendix, which is a bit subjective, that is not perforated, you can treat that as a simple appendicitis and you need no antibiotics whatsoever post-op. In fact, we discharge all these patients home the same day. We've been doing that for years. The second issue is, why still stick to number of days? Why not just go by clinical response? I think there's ample data to show you that if the patient's afebrile, tolerating a diet, pain has resolved, maybe a normal WAC count, maybe not, that's controversial, they do well. And you do not change the course of post-op surgical site infection. So why still use a specific number of days?
Right. Okay, those are 2 good points. So I'd say generally, this is our institution, right? So just in 2020, we were treating gangrenous with 3 days, perforated with 7 days, right? Which I agree with you is different than data coming out from a lot of other places. So this is an effort of showing that using clinical practice guidelines, you can change your institution stepwise at a time, because not every institution is using no antibiotics for gangrenous. But I think that's a good point, and but I lump that all in together. And then your second question was going off of how well the clinical status of a patient is. This was an easier way for us to have a more standardized regimen that everyone could follow and show that our clinical practice guideline could work. There were efforts before my time of white blood cell counts and things like that, and using clinical data to change how much antibiotics we're giving, but there was so much variation practitioner to practitioner that this is the direction that our team went for. And if you want more specific answers, we have a lot of Larry's people here too. I'm happy to talk to you.
Yep.
Yeah.
Thank you so much. For the interest of time, we're just going to ask you to connect afterwards.
Well, I think we'll figure out appendicitis in about 20 years, we'll say. The next presentation is the development of a multidisciplinary gastrostomy tube perioperative care bundle in the neonatal intensive care unit, decreases operative enteral access complications. This is presented by Dr. Michelle Honegger.
Hi, thank you so much for having me. I'm one of the NICU fellows at Johns Hopkins All Children's Hospital. We have nothing to disclose. Just why we did this project. So one of the most common G2 placements, one of the most common life-sustaining procedures done in both neonatal and pediatric patients. Yet complications have been reported nationally from 11 to 26%. There's minor complications, excessive granulation, tissue formation, osteo leak with subsequent skin breakdown, G-tube malfunction, while more serious complications can include early G-tube dislodgement, surgical site infection, and sepsis. So in our NICU, we performed a baseline assessment, and we found that we had a 30% complication rate. You can see one of our images here. And we identified during a drill down that we just did not have a standardized postoperative care bundle. So we created a multidisciplinary task force, including representatives from neonatology, surgery, anesthesia, wound team, nursing, as well as other departments. And we hypothesized that creating this bundle, we could decrease our postoperative complications. And our goal was to reduce them from 30 to 15% in an 18-month period. We included infants in our scope who had surgically placed G-tubes with or without fundoplication procedure. And our operative bundle provided guidance through the 6 weeks post-op or at discharge, whichever came first. This was our key driver diagram when we were performing our project. We wanted to look at different areas from the pre-op planning to standardization of securement within the OR to nursing care and post-operative securement of the G-tube, as well as the post-operative feeding plan and pain control. When drilling down on our own complications, we found that most of the complications were in fact related to the skin, with the majority, as you can see here at the Prieto chart, we had cellulitis and leakage as the most common issues. So we spent a lot of time trying to decide on how to standardize our securement technique, and we adopted this hashtag securement. The Nemo fish is optional, but the babies would come back from the OR with the steri strips in place, and we were to maintain those in place for 5 days. And then the surgical team would be with the bedside nurse, and then change that over to a Membatac, more gentle dressing, and the nurses could carry out those changes thereafter. Our first PDSA cycle really kind of focused on developing other components of the standardized care. We looked at cleaning techniques, kangaroo care, and giving medications through the G-tube, and just worked on disseminating that to the nursing as well as the providers. We then really focused on our second post-PDSA cycle on really focusing on the securement. We obtained a consensus from all the surgical team to carry out the hashtag securement, and then we took it to the bedside, provided a lot of teaching and reinforcements of maintaining this securement while the patient's admitted. Our third cycle was allowing, we created this bedside reference card to make it easy for the nurses to remember, just to kind of identify a quick reference of when the G-tube was placed, when's the first dressing change going to be, and just a little bedside reminder. You can see here on our run chart how this intervention just kind of changed our complications over time. So really you can see once we implemented the securement changes, we had more significant changes in our complications, and we ended up with a 17% complication rate. And then when looking at our complications specifically, you can see cellulitis, leakage had significantly decreased, and granuloma formation, based on chart review, had decreased to 0 reports. We had also severe leakage had gone down, and we, in both cohorts, did not have any patients with early dislodgement. When we were doing some bedside audits, we found that our babies were coming back with 100% of the hashtag of the time from the OR with their hashtag in place, and we also had continued use of the hashtag at 88%. We had also had 100% daily cleaning and appropriate wound care. So for our next steps in sustainability, we had undergone a CPG change within our neonatal department on pain control and feeding, so we want to analyze our data on that standpoint. We're going to continue monitoring our G-tube care bundle compliance, and efforts have been made to spread this to different areas of the hospital. And we also are going to be creating a post-operative discharge teaching packet just for the families as well. In conclusion, we noticed a positive decrease in our NICU for enteral tube-related complications. And following the implementation of our bundle, we attribute the success primarily by the fact that we ended up having a 100% buy-in from our surgical colleagues, and we provided a significant amount of nursing education and reinforcement. And then another key component to our success was the creation of the standardized securement pathway. So thank you so much.
We'll open up to discussions. You guys pick it out.
Joe Fusco, Nashville. Thank you for this. This is a problem that we deal with really often. Do you think that the key to the intervention was truly the securing of the G-tube, or do you think that probably you focused on an issue, you have a really comprehensive plan? I just wonder, did you look at like cleaning before and after versus, or was it truly, you think the securement was the main thing?
I think the securement was the biggest piece. I don't have any like concrete data, but just by speaking to the nursing, we had some nursing that did say about cleaning, they didn't clean it for maybe 7 days. Another nursing said immediately the second the baby came back. So I do think this did provide at least a reference for how to do different bedside care. But I do think the biggest thing here for us was this fact that there was less rocking of that G-tube and the babies were able to just have less leakage and kind of going through that cascade. Thank you.
Mine is more in the way of a comment. Stuart Lacey, Banner Children's here in Phoenix. One of my observations is that, at least in my career, there seems to be a tremendous overdiagnosis of cellulitis at the site of G-tubes that is frequently secondary to leaking. Nothing that you did in your care plan would suggest that it should decrease cellulitis, and you had a very high diagnosis of cellulitis to begin with. So I would say that supports the theory that much of what was being called cellulitis was not indeed cellulitis. It was skin irritation from leakage and movement. So I think that's why you saw the big improvement in that.
Thank you so much for your comment, and I do agree.
So a follow-up question on the previous questionnaire. Many of us feel that securing is not as important as leakage. Did you increase the use of ferrule bags and venting during this time period? And would that be more of an explanation? Thank you.
Thank you for your question. In our NICU, we don't really use, we have like a combination of patients that use ferrule bags, and we do have a standardized venting. We did put that in our bundle, but we did not address like ferrule bags and add that on, but we did provide recommendations on venting.
Well, thanks very much. I do want to make a comment. I think I really appreciate the fact that you used your key drivers, data over time with your control charts. And I think from our committee, showing data over time with these types of metrics are really important. And so thank you for doing that.
Yeah, thank you so much.
Our next presenter is Monica Milovanjev from Monroe Carroll at Vanderbilt, presenting on improving time to goal feeding and discharge after surgical gastrostomy tube placement in children.
Thank you for the privilege of the podium. I have no disclosures, and artificial intelligence was not utilized. So despite the large number of gastrostomy tubes placed in pediatric patients each year, at our institution there was a lack of standardization which created variance in practice and variation in outcomes, which sometimes led to delayed discharge after gastrostomy tube placement. Our goal was to improve the overall efficiency while providing safe care. I'm presenting today to demonstrate the safety and effectiveness of creating a comprehensive clinical practice guidelines. Our aim was to create a comprehensive CPG for gastrostomy placement, utilizing best practice evidence that would result in sustained decreased time to full feeds and postoperative length of stay within a year while accounting for a unique institutional workflow. During our literature review, we identified several studies that helped guide our CPG and confirm early initiation of enteral feeding was not associated with an increase in complications. We then assembled a multidisciplinary pediatric surgery quality improvement team to ensure involvement by all stakeholders. Our CPG was developed in February of 2022 and fully implemented in March of 2022. It was distributed and discussed with all providers on the service and presented at our APP team meeting, faculty meeting, and Department of Clinical Standards meeting. Nursing was also educated on the implementation of the new CPG. In February of 2023, we performed the first post-implementation review of our data when the CPG had been in implementation for almost a year and was an accepted standard of practice by our team. We then performed a maintenance review from February to December of 2023 to ensure continued improved outcomes. This is a copy of our comprehensive clinical practice guideline. So patients eligible for our clinical practice guideline are those undergoing primary G2 placement, and excluded are those undergoing G2 placement with concurrent more complex operations such as fundoplication or other major surgical operations which can affect post-op bowel function. To better prepare for discharge, we wanted to make sure our CPG was comprehensive, and this is why we felt it imperative to include not only specific feeding pathway, but also ensure it encompassed all components of the patient's care, such as education, supplies, and pain management. This comprehensive clinical practice guideline covers all postoperative gastrostomy placement patients and provides practice consistency across different patient populations. Currently, we use this pathway in all areas of the hospital with the exception of the NICU and the cardiac units, both of which utilize a slower advancement plan. For our study, we included those admitted electively for primary G2 placement, only combined with other simple operations such as hernia repair and circumcision. Patients excluded from this study were those who underwent other complex surgeries, such as Nissen fundoplication and other procedures by other surgical services that required a longer-term or ICU care postoperatively. Our patient ages ranged from 9 months to 7 years. Our results showed that there is a statistically significant decrease in postoperative median time to full feeds, 25.8 hours to 19.3 hours, and a statistically significant decrease in the postoperative length of stay, from 30.6 hours to 27.1 hours. The maintenance cohort showed sustained change with additional slight improvement in postoperative length of stay. There was no significant change in our balancing measures of postoperative emesis or return visits to the ED within a 30-day time period. We also used QI analysis using an X chart to evaluate if or when our clinical practice guideline was cause for change. We can see a shift in the center line change over time, with the cause of change being the development of our clinical practice guideline, which included a standardized post-op feeding regimen. We used 8 consecutive points below the center line to indicate a shift in the center line defined by Cincinnati criteria. This change was sustained in the maintenance period. This X chart demonstrates by creating and implementing a comprehensive clinical practice guideline, time to discharge postoperatively decreased from the pre-implementation to the post-implementation period. This change is attributed not only to the initiation of post-op feeding sooner, but also by preparing patients for discharge even prior to placement by involving case management and a dietitian early to help ensure barriers such as waiting on equipment and nutrition recommendations could be avoided to prevent delays in discharge. In addition to the post-implementation shift, there was a small further incremental decrease in the time to discharge in the maintenance period, with further decrease in variance. Although not fully clear, this incremental change may have been a result of the addition of a dietitian in our pediatric surgery clinic where patients were evaluated preoperatively. So in conclusion, this study demonstrated sustained compliance to a CPG, promoted decreased time to full feeds, and postoperative length of stay after G2 placement. This improvement did not result in an increase in postoperative emesis or ED visits. It decreased variations in practice. Important key lessons I've learned were that ensuring all stakeholders across the enterprise were involved and encourage input from all parties and include them in decision-making when necessary. Present the CPG and give a chance for questions and concerns from all the frontline providers. And finally, to have a set launch date to decrease confusion and decrease last-minute scrambling. Adopting comprehensive clinical practice guidelines may lead to decreased variations in postoperative practices and improved throughput for the hospital by providing a standardized pathway for all clinicians. An area we could further investigate would be the impact this has on cost and resource utilization. To further decrease length of stay, our institution is in the early stages of designing a CPG to implement same-day discharge after G2 placement for a select patient population. These are my references, and thank you to my APP team, all the surgeons, and especially to Dr. Wong for helping make this possible. Take any questions.
Thank you for that great presentation, and I just want to commend your use of QI methodology during that study. Those control charts really nicely demonstrate, I think, the impact of your interventions, and especially seeing that confidence interval tighten with your decreased variability was great to see. I'm just curious, in the implementation of this, what were the barriers you encountered in getting people on board and trying to get this to be fully embraced or adopted by the team, and kind of what solutions or processes did you go through to address that?
That's a good question. It's sometimes hard getting everyone on board. Some of the barriers were obviously we had to come up with a time frame that everyone was comfortable with for starting feeds. But there's plenty of evidence out there showing that a decrease, we had previously kept kids overnight, so we chose 6 hours for our time frame. And then some of the other barriers were just all the other things that it takes to getting a kid home for that got a G-tube. So getting case management on board was key, getting the supplies, and then talking with nutrition was probably one of the biggest barriers. Previously, they wouldn't see our patients until they were already up in a room, admitted to a room after G-tube placement. And so we wouldn't get those recommendations until we were wanting to start feeds. So that was probably one of our biggest barriers.
Hello. Hey, Doug Miniotti from Kaiser Permanente in Roseville, California. Thanks for your presentation. If I got this right, your gap after attending full feeds to discharge was about 6 hours. What happens during that time period, and is there any reason that it has to be that long? Are there other things going on that you can tighten that up?
It's a great question. I'm not sure. I'd have to look at that. I know some of the barriers are obviously like social barriers. So making sure patients have a ride. Sometimes we're waiting on the supply companies to bring the equipment to the hospital, and do that education with the families.
A similar protocol in our institution, and we've employed our patient care coordinators to arrange for getting the supplies sent to their home instead of having them have to wait to get like any extra devices before leaving, and that's been something that's helped accelerate our discharges.
It all depends on the patient's insurance at our place. So some companies will bring it to the hospital, some will send it to the home. It really is patient specific. So that's why we love having our case managers, because they can help us navigate that.
Absolutely. Congratulations.
The next presentation is iterative quality improvement in opioid stewardship improves care and pain control in appendix excavatum surgery, presented by Krista Satyak.
Thank you very much. We have nothing to disclose. Pain management strategies for pectus excavatum have evolved. As we strive to provide the best care for our patients, we did this research to evaluate our own quality improvement process and to ask the question, have we also improved? We are presenting it here today to demonstrate how iterative quality improvement driven by evidence-based research impacted our practice. This is important because in doing so, we were able to dramatically improve care for our patients, and that's why we're all here, right? Minimally invasive repair of pectus excavatum has historically been a painful procedure, requiring multi-day admission, often primarily for pain control. Pain management strategies have included epidural, patient-controlled analgesia, or PCA, multimodal pain therapies with nonsteroidal anti-inflammatories, cryoanalgesia to the intercostal nerves, and regional intercostal nerve block with long-acting formulations such as liposomal bupivacaine. Advances are being made towards decreased narcotic utilization, minimal hospital stays, and even same-day discharge. In 2011, we were primarily using epidural and PCA for postoperative pain management. The implementation of iterative quality improvement was based on the evolution of surgical techniques and pain control strategies. Temporally, we have adopted both cryo and liposomal bupivacaine for long-acting anesthetic. Throughout this process, there has been some overlap while we figured out what was working and what was not. For instance, as you can see in 2021 and 2022, there were patients who received cryo and nerve block and continued to receive a PCA. At this time, our pathway included pain management consult. However, we were able to identify that this wasn't needed for routine care, and we were able to eliminate both the additional consult and the PCA. In this study, we aim to assess opioid use, length of stay, and total hospital costs, first with the implementation of cryo, and second with the implementation of liposomal bupivacaine nerve block. This is a single-center retrospective cohort study of opioid utilization, length of stay, and cost in all pediatric patients who underwent pectus repair from 2011 to 2023. Specific focus was placed on quality improvement in multimodal pain regimens and techniques evolved. The cohort groupings were based on the pain management strategy received. Opioids were converted to milligram morphine equivalents, and the hospital costs were assessed from the system's perspective using hospital accounting data and inflated to 2023 US dollars. Generalized linear regression was performed, controlling for patient risk factors such as age, gender, Haller, and major comorbidities. Of the 71 patients who underwent pectus repair, 85% were male, with a mean age of 14.8 years and a mean Haller of 4.4. We identified 7 treatment groups within our study period. 54 or 76% of the patients received cryotherapy. Our largest group is our current treatment group with 23 patients who received cryo plus liposomal bupivacaine nerve block. The dotted line on this run chart represents the length of stay. The mean length of stay in the epidural alone group was 5.5 days and declined steadily by intervention group to only 2.3 days for cryo and nerve block. This solid line represents the total MME per patient over time. Interventions demonstrated gradual improvements in opioid consumption. Overall, a 90% reduction in opioid utilization was observed from epidural alone early in the study period to the current intervention of cryoanalgesia with liposomal bupivacaine. The MME in the first 24 hours saw a similar trend. You can see here that the MME per day in the epidural alone group was 72. This decreased to 27 in the cryo alone group and further to 21 in cryo with liposomal bupivacaine. Notably, there were 2 patients within our current treatment group who did not require any postoperative narcotics. Prior to the implementation of cryo, 0 patients were able to be discharged without an opioid prescription. However, 44% of our current patients who have had cryotherapy were discharged without an opioid prescription. In multivariate analysis, the mean absolute incremental difference in the length of stay was 2.3 days less with cryo compared to no cryo. The mean absolute incremental cost was $456 less for the cryo group than for no cryo. In conclusion, despite cryoanalgesia and intercostal nerve block increasing OR costs, in our system, the associated reduction in length of stay provided a net neutral expense and improved care for our patients. Thank you very much.
Hi, Kurt Heiss from Atlanta. What happened to the oral medications during this time? I may have missed that earlier. The NSAIDs, Tylenol, maybe a nerve agent like gabapentin. I didn't see how those changed or if they were contributing at all.
Yes, absolutely. I would say that throughout the study period, there was inconsistent use of those sort of agents. In our current protocol, we definitely do have both preoperative and postoperative use of NSAIDs and gabapentin, and specifically ketorolac use at the end of the case. In this specific study, in the entire cohort, 82% of the patients received postoperative NSAIDs, but that was in the retrospective nature of this study, that was not consistent enough for us to have controlled for in the 7 different cohort groupings.
Excellent presentation. Thank you so much. Lauren Guillory from Dallas. I think that it's great what y'all are working on, and some other institutions, including our own, we've been able to push really for discharge earlier and earlier, and most of our patients are going home post-op day 1. Is there any plans to try to implement that at your institution, and do you see any barriers for that?
Yeah, I think we're definitely on the way to that, and we have patients currently in our cohort that are going home the next day. And we've been using the cryo with the liposomal bupivacaine since about late 2020. So as we get further out with that intervention and have optimized our non-opioid pain control additionally, we're definitely trending towards more like a 24-hour or this next day time frame.
One more question.
David Klima from Boise. On the blocks that you're doing with the liposomal bupivacaine, we've had some hesitation from our anesthesia group, in particular about deciding on erector spinae versus paravertebral blocks. I was just curious as to what your team was using for the liposomal.
Specifically, we're using our liposomal bupivacaine in our intercostal nerve blocks. So we perform the cryoanalgesia to 3 through 7, and then following that procedure, we the calculation of the liposomal bupivacaine, we do each at the same site. Thank you very much. I appreciate the opportunity.
Next, we have Dr. Sharissa Smith presenting on implementation of a neonatal surgical feeding advancement clinical care guideline from Northwestern.
Thank you for the opportunity to present our work. We have no disclosures. Advancing feeds in the NICU for infants after intestinal surgery is highly variable and provider dependent. It's often due to clinical fears of initiating and advancing feeds too early or too fast that may result in harm in this vulnerable population. An ideal feeding strategy requires a delicate balance of providing adequate nutrition for growth and development while avoiding feeding-related complications such as neck, CLAPSIs, and liver dysfunction. Standardization of feeding advancement using clinical care guidelines, also known as CCGs, has been successful in improving NICU outcomes while avoiding complications in non-surgical preterm and term infants. However, little to no guidelines exist for surgical infants. The purpose of our study was to evaluate if a CCG could decrease practice variation and feeding initiation and advancement and decrease NICU length of stay at our institution. This research is important because developing a comprehensive feeding CCG for surgical infants could be adopted at other children's hospitals using QI principles. This study was a pre- and post-intervention design established in the NICU at our single-center academic children's hospital as an ongoing quality improvement project with data starting in September of 2022 to April 2024. After conducting an extensive literature review, a multidisciplinary team from the NICU, pediatric surgery, and nursing came together to design a comprehensive feeding guideline to help with infants undergoing intestinal surgery. Eligibility criteria included infants admitted to the NICU who underwent one or more abdominal surgeries for the following diagnoses and/or procedures listed on the right. Typical cases were infants with non-complex intestinal atresias, simple gastroschisis, and neck that did not require extensive intestinal resection. Exclusion criteria focused on infants with complex GI conditions such as complex gastroschisis or with comorbidities such as significant congenital heart disease. A baseline population of surgical infants meeting eligibility criteria and discharge from the NICU was collected in an 18-month interval prior to the start of the feeding guideline implementation and served as the pre-intervention group, with all subsequent eligible NICU infants enrolled in the post-intervention group. So given the heterogeneity of the infant surgical population, there was an innate challenge in creating a one-size-fits-all feeding guideline for postoperative feeding. Therefore, we stratified infants into two groups, standard and high risk, which we determined the rate of feeding based on their weight, gestational age, and diagnostic criteria. Simple diagnoses were categorized as standard risk outlined in green, whereas the more complex diagnoses were outlined in red. By stratifying patients into two groups, infants seen as having a higher clinical risk of complications could be started at lower feeding rates and advance slowly. The outcome measures in the study was length of stay, time to full feeds, and time to CVC removal. Balancing measures were the incidence of post-surgical neck and increased stool output. And statistical analysis was used to detect differences between outcome measures also using the creation of SPC charts. So, a total of 139 surgical NICU infants were included in this study, 87 infants in the pre and 52 infants in the post group. There were no significant differences based on sex, race, gestational age, or birth rate between the two groups. Unfortunately, no significant differences were detected between pre and post intervention groups when measuring NICU length of stay. This was reflected in the control chart showing no significant shifts in NICU length of stay after the initiation of the feeding guideline, represented by the dotted red line. Additionally, no difference was seen between groups for time to full feeds, with similar results in the control chart as well. However, while no significant difference was seen in the bivariate analysis, there was a significant shift in the decrease in time to CVC removal to TPN discontinuation noted after the feeding guideline initiation on the control chart. In terms of balancing measures, there were no incidences of post-surgical neck or increased stool output noticed after the initiation of the feeding CCG. So in conclusion, there was no difference in NICU length of stay observed after initiating our feeding guideline at this point. These results may be due to delays in initiating feeds after surgery or perhaps insufficient adherence to the guideline once initiated, or a high number of infants switched from standard to high-risk feeding protocol, which would result in slow feeding. Greater patient enrollment with longer periods of monitoring is needed to evaluate the effectiveness of the guideline. And additional PDSA cycles looking at process measures such as timing to initial feeds or order set utilization in the EMR are needed to optimize our CCG adherence. Nevertheless, we've shown that the development of a feeding CCG appears feasible and safe with no increase of adverse effects. And then this is a QR code to the toolkit. Thank you for your time.
Thanks for that presentation. A couple of questions I just had. So if I'm understanding this correctly, in your guideline, say a baby with Hirschsprung's disease, regardless of how well they were doing, they would still get advanced at 20 mils per kilo per day. There was no escalation to just ad lib feeds or anything like that?
So basically, this is like the initiation of feeds, and we advance using the order set. Now, I do think that there is clinical decisions made because part of our guideline was that pediatric surgery and the NICU had to reach consensus. So I think if they talked to each other and agreed they could advance faster, they could. But just this is kind of for like the beginning stage to start it in like the first couple of days.
Okay. Yeah, my first question very similar to that. And then my second question is, do you have a guidance on what type of milk was being given to the infants?
So there was more of an extensive literature review where we agreed on like several like general recommendations for like breastfeeding, like breast milk was the preferred option. And then milk, like we had like I guess what I would say is, yes, there's like a lot of different recommendations that we have for that. So breast milk was preferred.
Yeah, quick question. Thank you. Very nicely presented. Two quick questions. Were neonatologists involved in the decisions, or was this just surgical? The neonatologists were involved. And I may have missed it on your slide, but did you look at actual compliance? Because you just hinted at it. Because guidelines are great, but the question is how compliant are people with them? And feeding seems to be visceral for so many people. Like they either want to advance quick or they don't want to advance at all. So I'm just curious if you gauge that.
Okay. First question. So this was created by a multidisciplinary team. The NICU was very much involved, nursing staff, quality improvement, pediatric surgery. So we often also have meetings to talk about the guideline as well. And in our guideline, we pretty much have to meet consensus on whether we put them on a standard or high-risk group. So it's kind of like an ongoing conversation between pediatric surgery and the NICU. And then the second question is, we realized that as we started implementing the guideline, we needed to focus more on process measures to make sure that we were adhering to it. So I think one of the bigger initiatives we're looking at now is seeing how well the order set is being used. Like, is it being initiated? Is it being followed or canceled after a couple of days, to see adherence and see how well that's working? Because I think that that was one of the worries when we were looking at our results so far. And then the question of, are we starting infants on standard and then switching them to high risk? Because that also could affect our outcomes as well.
So much.
Mm-hmm.
All right. Our final presentation will be presented by Dr. Fall on increasing caudal block utilization to promote opioid stewardship in the NICU population from Nemours DuPont.
Thank you for the opportunity to present. We have no disclosures. So we did this study because the myth that neonates feel less pain than adults has long been refuted. And opioids are frequently used as first-line treatment for postoperative pain, but are associated with several side effects, ranging from respiratory depression and apnea to opioid-induced hyperalgesia and tolerance. Regional anesthetics are underutilized in neonates, despite being safe and effective opioid-sparing adjuncts with both intraoperative and postoperative benefits, such as decreased duration of mechanical ventilation and earlier return of GI function. Therefore, we put together a multidisciplinary team to develop an opioid stewardship pathway for NICU patients who are undergoing elective abdominal surgery using single-shot caudal block. By routinely using caudal blocks, we hope to increase the intraoperative extubation rates while decreasing opioid utilization. For balancing measures, we wanted to make sure that we were not increasing the incidence of unrelieved postoperative pain. We therefore aim to increase caudal block utilization from a baseline of 50% to 90% within 18 months of pathway implementation by engaging NICU, anesthesia, and surgical stakeholders, standardizing criteria for caudal block use, and providing ongoing education. All NICU patients who are undergoing elective abdominal surgery, defined as cases scheduled at least 1 day prior, were included. Patients who were already intubated pre-op or had contraindications to caudal block use, such as coagulopathy, inability to obtain consent, or spine abnormality, were excluded. Here we have excerpted a sample of the simple pathway with criteria for caudal block utilization, intraoperative extubations, and monitoring in the NICU post-op for opioid utilization and pain control. The full pathway is available in the APSO Quality and Safety Toolkit. There have been 125 surgeries pre-implementation and 48 since implementation. The two groups were similar in age, weight, and OR time. Most surgeries were gastrostomy tubes and ostomy closures. We use control charts to track quarterly outcomes. Since pathway implementation in Q1 of 2022, the caudal block utilization rate has increased from a baseline of 49% to 63%, while intraoperative opioid use has decreased from a mean of 0.4 oral morphine milligram equivalents per kilogram to 0.2. While intraoperative extubation rates has increased from 70 to 75%. The rates of post-op unrelieved pain, which is defined as 2 consecutive NPAS scores greater than or equal to 4, at least 1 hour apart, increased from a mean of 25% to 29%. However, the rates have remained at or below the center line in the last 3 quarters. Given that only 60% of eligible patients receive caudal block since implementation, we test the association between quarter block use and outcomes of interest. Quarter block use was associated with a significant increase in intraoperative extubations, decrease in opioid utilization, with no impact on the rates of uncontrolled pain post-op. As you can see, our biggest challenge was changing the culture to routinely use quarter blocks. Therefore, we conduct case-by-case review of failures to use quarter block to identify and address opportunities for improvement. Our ongoing educational efforts include sharing the positive association between quarter block use and the rates of intraoperative extubations and reduced opioid utilization, and also changing the handoff process to include a routine discussion of the anesthetic plan, both in the preoperative and postoperative handoff. We have also amended our protocol to implement QL block for patients who are not candidates for quarter blocks. These results demonstrate that a simple intervention using common regional anesthetic techniques has measurable benefits for NICU patients who are undergoing surgery. The protocols and our tools are available in the APSA Quality and Safety Toolkit for others who may wish to replicate our results. Thank you for listening. I know lunch is almost ready.
Thank you for that. I had a question about, I was trying to figure it out from your tables, but do you have a sense of what the average time was for the anesthesiologist to perform the caudal blocks and kind of how that added into the operative time length and kind of barriers from a surgeon's perspective of kind of adopting this technique or being a fan of it?
Yeah, so the caudal block use actually did not increase the operative time. Things have been simple. The reason why we went with the single shot caudal block is because like most of our anesthesiologists and CRNAs know how to use it, and it's just a simple inject the ropivacaine and you're done pretty much. Yeah. So from a OR cost perspective, we don't think that it has added to it, but we can closely look into that.
You mentioned that there were kind of surgeon barriers to adopting. You said surgeon refusal. Just curious in your feedback with these surgeons, what were the things that were brought up?
The fear was delay with the OR time usually, yeah, especially with late cases.
Thanks everybody.
Thank you.